Welcome to the webinar, Helping Patients Change, Adherence with Healthcare Plans. Hi, I'm Barbara Lewis, the Managing Editor for DocCom, which is an online communication skills learning system for medical schools, residency PA and NP programs, and hospitals, now that DocCom offers over 40 CME credits. Joining me today is Dr. F. Daniel Duffy, a professor of medical leadership at the University of Oklahoma. He's the co-author of DocCom's Module 16, Promoting Adherence and Health Behavior Change, and he is currently updating one of our modules to include telehealth. Welcome, Dan.
Thank you very much, Barbara. It's a pleasure to be with you today. As you mentioned, I'm the Langarden Professor of Medical Leadership at the University of Oklahoma, the University of Tulsa School of Community Medicine. I was at the American Board of Internal Medicine for a number of years, and currently I'm director of the Oklahoma Primary Healthcare Improvement Cooperative and principal investigator of the Healthy Hearts for Oklahoma Cooperative of the Evidence Now ARC program. My affiliation with the American Academy on Physician and Patient is that I am a fellow and was past chair of the board of directors. And that's enough about me. Let's move on to the topic.
Okay, thank you. The webinar will last about 30 minutes, and a recording and the PowerPoint will be available on the DocCom website very shortly. If you have any questions, you can type them in the chat box located in the panel, which usually displays on the right side of your monitor. If we don't have a chance to get to your question during the webinar, we'll respond afterwards. So let's get started, Dan.
Thank you, Barbara. So our learning objectives for today are to help you match motivational interviewing, or MI skills, to a stage of change for the patient. And I think everybody on the webinar probably is very familiar with the Prochaska stages of change. And we're then going to look at using motivational interviewing micro skills and tools to do three things. One is to evoke change talk, to have the patient actually make the argument for their own change. And we'll use the importance, confidence, and readiness rulers as structured ways of asking questions and probing deeper. We'll reduce sustained talk, and we'll use the decisional balance to help create greater discomfort with the ambivalence a patient has as they're trying to decide to change or not to change. And lastly, we will evoke internal motivation by using reflective listening and driving the patient's responses to a deeper level. So you're all pretty familiar with the stages of change of pre-contemplation, contemplation, determination, action, maintenance, relapse, and then the cycle repeats. And after a long enough period of time, and a long enough time in maintenance, many patients may adopt a new habit. This model is very applicable for almost any, making recommendations for almost any medical treatments. But we're going to be focusing largely on those treatments that require a behavioral change in the patient today. So let's look at some of the features of the change stages. And I'll start over here with pre-contemplation, in which we have a patient who is uninformed, or they're in denial or discouraged because they've tried to adhere to medication recommendations or tried to adhere to behavioral change and have been unsuccessful. It's pretty uncommon for us to find a patient when it comes to behavioral issues who's completely uninformed about the value of not smoking or eating a more judicious diet. The next area in the stages of change is moving into contemplation. And this is the stage where motivational interviewing has its greatest application. In this stage, the patient is ambivalent about the change. They know they should, but they don't want to. And they will say things like, maybe I'll do it in 6 months, but I'm not quite ready now. The issue here is there's emotional disturbance in the contemplation stage. And as counselors, we want to play on that emotional disturbance, amplify it, and tip the balance in favor of moving into determination, where the patient says, I must do it, and I must do it soon. They might even begin testing with going for a while without a cigarette, for example. When they move into action, the patient is actually saying, I am doing it. I have stopped smoking most of the time. I'm resisting cues to do it. but they slip often. And I think it's really important for us to get into the idea that change doesn't occur very suddenly, even taking medications like for blood pressure or COPD. What we want to do in this action phase is help the patient make the adjustments in their life to accommodate the new habit or the new treatment. With maintenance, we tend to divide it into two broad areas: short term, which is 6 months after adopting the new habit or the treatment plan, in which the cues are strong to keep doing it. There are fewer slip-ups. And then long-term treatment is up to 2 years. You notice we're not talking about adopting a new habit within that first 2-year period of time. And I think that becomes very useful for us as we realize this stage of change is really very active for quite a long time. Relapse is common, almost to be expected. We don't wish it for anyone, but it always means that in order to relapse, you have had to have had a success in adopting the new behavior. And then the success fades and we resume our old habit. What we want to emphasize is that at any time an individual has relapsed, they've learned a lot about the new habit or the new behavior and build upon that, particularly looking at what happened right before the relapse occurred. So let's move on and look at motivational interviewing. And remember, I said that it is most applicable in that stage of contemplation. I like Miller and Rolnick's definition that says it's a client-centered directive, and underscore that directive. It's a client-centered directive method for enhancing the intrinsic motivation to change by exploring and resolving ambivalence. So we've already set it up. The contemplation is about ambivalence. I want to change, I don't want to change. It was originally designed by Miller and Rolnick to help stop addictive behaviors, particularly alcohol addiction or drug addiction. What it attempts to do is to observe the patient, respect the patient, and not oppose sustained talk. In other words, go with the patient's sustaining the old habit talk. What we want to do is elicit, amplify, and affirm change talk. So it's a very directive, active method of helping the patient enhance intrinsic motivation. Let's look at 3 interviewing styles. The one on the left is the directing style, in which there's a lot of telling, a little bit of asking, and not much listening. On the right-hand side is what we call the following style, which is more the classic Freudian analysis, in which we do very little telling, a lot of asking, and a whole lot of listening. In motivational interviewing, we have a balanced approach in which we are guiding. This is not a passive role for the interviewer at all, but a very active role in which we use telling, asking, and listening. So let's dive deeper into these motivational interview skills of ask, tell, and listen. The first ask that is essential in motivational interviewing skills is asking permission. May we talk about this? May we deal with this? Could I bring up this topic? And asking permission immediately says that the clinician is attempting to give the patient full rein in this conversation. And yet, remember that it's directive as well. I'm asking permission to do something. And so what I'm asking to do will guide the conversation. The second asking are open-ended questions. My favorite question is, what do you know about this topic? What do you know about high blood pressure, or taking medication for high blood pressure, or taking insulin for diabetes? What do you know about it? It is the most time-saving question I think I use clinically, because I'm always surprised people who know a great deal, and I don't want to waste any time covering ground that they know, or there are people who really know very little about it and are eager to have some explanation. Closed questions are valuable at a point, but they become the least valuable questions for saving time, like how much do you smoke, which the answer to that question may come out in a conversational format using more open-ended questions. So these are the questions we ask. However, when we get to telling, there are three kinds of telling as well. One is to inform the patient, and we use this a communication style fairly infrequently, but remember this is a guided interview, so we'll have to have an opportunity to use information such as diabetes causes blindness, may be an example that we're using here. More importantly, we tell by giving feedback. So we tell the patient, this is what your tests show. This is what my examination suggests. This is feedback. And we follow that very quickly with an open question. What does that mean to you? What do you think about that? And so on. Lastly, we can tell by advising. And this is one we use very cautiously in motivational interviewing. And again, advice has to be linked almost always with permission. May I give you some recommendations? Would it be helpful if we talked about this? Now we come to the listen part. And listen is not just sitting back and saying, shaking our head, but it is actually a lot of talking with the listening. This is what we call active listening or reflective listening. We listen by appreciating, such as making a statement, you are very courageous, or reflecting what the patient says. And this is reflecting the ambivalence. You want to change, but on the other hand, you really don't have any idea how you might change. I hear you say this, but you'd want to do that. It's reflecting the ambivalence. And lastly, a skill that we use frequently is summarizing. And periodically throughout the motivational interview, we'll ask, let me see if I got it. Let me see, this is what you're saying here, and this is what's happening there. So, in motivational interviewing, people talk about the ORs, open-ended questions, appreciative reflection, reflecting what the patient said, and summarizing. The OARS are the most important interviewing skills of motivational interviewing. So let's dive into some of these in a little bit greater detail. We start by asking permission, which demonstrates respect for autonomy. We show a desire to collaborate from the very beginning, and we ask for permission before addressing a target behavior. For example, do you mind if we spend a few minutes today talking about your health and smoking? If you don't mind, I'd like to spend a little time today visiting about how Johnny's weight may affect his overall health. One of the things in our conversation with the patient we want to do is avoid stimulating sustained talk, because when we do, that often evokes resistance in the patient. And there are several known ways to do this. First is any kind of confrontation, disagreeing with the patient, arguing, correcting the patient, shaming, blaming, criticizing, labeling, moralizing, or ridiculing. All are ways that we guarantee the patient is going to respond with resistance, and now we're into a wrestling match. As already said, that advising without permission usually comes across as directive and stimulates resistance. And lastly, over-directing, giving commands and orders or imperatives. You should do this, you must do this, again, are ways of evoking resistance. What we want to do is evoke change talk. And we do that with open and orienting questions. We've already talked about what open-ended questions are, but the easiest definition I use for that, an open question is a question that only the patient can answer. Nobody else really would know the answer, such as, what do you think about this? What do you know about this? What experiences have you had? Another kind of open question that evokes change talk is what we call a scaled question with a follow-up of why or what would it take. And there are three that we're going to talk about in a few minutes. The first is a scaled question about readiness to change. How ready are you to do this? The second one is, how important is it that you do this? How important is it to you to do this? And the third is confidence. How confident are you that you'll be able to do this? And then we ask people to score those readiness, importance, or confidence on a scale from 1 to 10, with 1 being not at all and 10 being entirely ready. And then we follow up with the why and what would it take questions. And we'll show you that in a minute. We also have values clarification questions, which are really terrific for stimulating the ambivalence and tipping the balance toward action. And these questions are: 2, what do you like about smoking? What worries you about your smoking? What do you like about the idea of being a non-smoker? And what worries you about becoming a non-smoker? These are questions that help clarify the patient's ambivalence and tip the balance toward action. So let me show you how a confidence and confident ruler actually works here. And here's a actual ruler, 0 to 10. Not at all convinced that it's important for me to change the new behavior. And so how convinced are you that it is important for you to take this medication, follow this regimen? And in this case, the patient circles a 4. And remember, we follow that. Why a 4? Why not a 6? And a question like that dives deeply into the patient's motivations and their values and what's going on. It's a very simple way to begin to have this conversation. Likewise, we can ask, how confident are you that you will change to this new behavior, that you'll be able to take your blood pressure medicines on a daily basis? And again, if they select a 5, we really do want to know, what would it take to move from a 5 to an 8? What would it take to become even more convinced? This can be fairly useful in determining what stage of change the patient is. So anything less than 7, you can be pretty sure the patient is not motivated to make a change or to sustain and do the work that's necessary to adhere to a complex behavioral change regimen. Let's go now to those amplifying ambivalence in the contemplation to action step, where we elicit change talk. What we want to do here is amplify the ambivalence about changing behavior or adopting a new regimen by asking, what do you like about the old way and what do you worry about it? And what do you like about the new way and what do you worry about it? This elicits discomfort, helps tip the balance to just get rid of that ambivalent discomfort, and it helps the patient argue for the change. As a clinician, as the interviewer or therapist, we need to roll with resistance. As the patient brings up reasons not to change, we accept it and then twist it slightly, using the patient's own words to move to the other side of the decision. So the way we put this together is with a 4x4 table in which we list the reasons not to change, and we have sustained talk, what do you like about the current habit, and reasons to change, what worries you about the current habit. And then we put in the second row the change to a new habit or behavior, what worries you about adopting that new behavior. For smoking, one of the greatest worries is people are afraid they will gain weight. And then we say in the fourth quadrant, what do you like about the idea of adopting a new habit? Now, if you look at this, we've lined up reasons on the left-hand side, the reasons not to change, and reasons on the right-hand side are the reasons to change. And I can say almost categorically that if you have 10 items listed in column on the left side and 2 items on the right side, patient's not ready. There's not enough pain in that decisional balance. A couple of final comments about motivational interviewing. We use empathic reflective listening. We've talked about that in the listening step. We respond with reflective statements in which we restate, rephrase, use metaphor, and summarize what the patient has said. The purpose of this kind of feedback is try to reflect the patient's true meaning of what they're saying. This kind of working with a person builds rapport. It enacts collaboration, shows empathy and understanding. And above all else, it supports the autonomy and self-expression of the patient, because we as the clinician are not using our words. We are using the patient's words and taking them to a deeper level. Just a word about reflection. Not all reflections are equal. A simple reflection is something we see all the time in our interviews. It conveys understanding but little meaning. It demonstrates, I'm listening to you, I heard what you had to say. But complex reflections, which is what we're talking about here, add meaning or emphasis to what the patient has said. It verbalizes the patient's affect or emotion. It elucidates themes or connections that the patient may be unaware of. It summarizes. Most importantly, it demonstrates, I understand. I feel the pain that you're feeling. I appreciate what's going on. So other skills are advise and educate, always with permission. Give permission to talk about giving advice, and give permission for the patient to completely disregard what you have to say. I'm not sure if this would work for you. Only you can tell what will work. But my advice would be this. Collaborate on solutions or plans by offering a menu of options for addressing the problem, and always explore the patient's ideas of what would be a goodness fit or next steps. We affirm and support the patient's autonomy. We reinforce good choices or ideas with praise and encouragement, and make statements of compassion or empathy when the patient can't quite go as far as we would hope they would. We emphasize choice, autonomy, or control, and explicitly respect the patient's choice. It's up to you. Nobody can make the decision for you. You know yourself better than anyone. And I may not agree with your choice right now, but I support your right to make it, and we'll keep working with you until we reach our goal. So my question for you is, did we reach our objectives? Did we describe the cycle of change? Did we contrast motivational interviewing with usual medical interviewing? And do you have a better idea now of some motivational interviewing micro skills in which we evoke change talk using the importance, confidence, and readiness rulers? And we tip ambivalence, reducing sustained talk by using the decisional balance. And lastly, evoke internal motivation by using reflective listening, the open-ended questions, appreciation, reflection, and summarization. Barbara, I think that's the end.
Okay, and I'm just going to talk a little bit about DocCom before we move on here. So let me change so that people can see my screen. And hold on one second, let me bring it up to full screen here so you can get more information from the module 16, Promoting Adherence and Behavioral Change. And thank you so much for that great information on such an important topic. So just a little bit about evidence-based importance of communication skills. You probably all know that certainly communication skills improves medical outcomes, decreases malpractice claims, enhances physician and provider satisfaction. And also recently it's been proven that good communication skills are affecting HCAP survey scores. So as you probably know, HCAPs, the patient satisfaction surveys, are mandated by the government, and that the two communication dimensions on the HCAPs actually are driving the scores. And there's a number of companies that have done this analysis on hospitals and institutions and have found that the communication dimensions are what really helps. If you have any questions, please put them in the chat box or the question box, and we'll answer them at the conclusion of our webinar today, which will be in a few minutes. I did get a question if there will be access to the slides, and yes, the slides and the recording will be available on the DocCom website very shortly. So DocCom is comprised of 42 modules, each about an hour in length. We have over 40 CME credits, over 400 videos that are realistic and unscripted. And when I've done surveys across all of our segments, all of our users, we're finding that this is what people really love. They love the videos. We also have annotated videos, which are very interesting. We have over 100 annotated videos right now, and we have a whole back end for faculty resources as well. So the modules, each of the modules are very consistent. They start with a rationale, key concepts, learning goals, content, and with plenty of videos interspersed and a behavioral checklist and lots of references. So we're not just saying that we think that you should say this because that's what we think, but it's based, everything we have in DocCom is all based on evidence. So here's an example of one of our 104 video examples, and this is in our module 33, which is delivering bad news. So as the physician is talking to the patient and her husband in this case, getting bad news, that it's going down through here and saying the wish, I wish it were different. And then if you click on the icon here, out pops the physician and he'll tell you what's going on in the back of his mind, which is quite interesting. We have a number of what we call comprehension scores. This one is on empathy understanding. So the clinician is not empathic at all with the patient. And what happens here is that as the listener is going through it, checks a spot where there are empathic comment could have been made. And of course, a lot of reasons why clinicians don't think an empathic comment should be made is because it takes too much time. But research is showing the exact opposite, that the interview moves along a lot faster when the clinician responds with an empathic comment. So we have several of these. Another one is to test the facial recognition. So in this case, you look at his face for 5 seconds, then 3 seconds, and a microsecond, and then click which one of these it is, and you can score yourself and test yourself. We have a lot of resources for the faculty, a facilitator guide, an administrative guide. And I'd like to tell everybody today that you get a free 30-day free trial subscription if you use this code when you log in, WEB, SEP, for September 17. So Dan, thank you so much for talking with us about this very important topic today.
Well, you're very welcome, Barbara. My pleasure.
And we hope you'll be back again talking about telehealth when that portion is complete of the model that you're updating. And thank you to everyone who has joined us. The recording and the PowerPoint, as I said, will be available on our website shortly. Thank you very much.